Hello everyone, this is Chadi Alraies from NYEVS. I'm really privileged to be with Dr. Eric Secemsky to talk about the approach to calcified lesion in challenging patient with FemPop disease. Eric, always nice to talk to you.
Nice to see you again, my friend.
This disease is non-stop, but the approach to that problem is evolving. So tell us about the best algorithm or approach to this issue.
Yeah, so we discussed nicely at the meeting today just different strategies for femoropopliteal disease in general, and then in particular calcified femoropopliteal disease. And you know, in the past we spent a lot of time thinking about atherectomy devices, but more and more we've been moving to these intravascular lithotripsy devices, and we're encountering a year where we're going to have more than one device available on the market. We traditionally only had Shockwave, but now Boston Scientific's bringing the seismic IVL platform to market, and we have a couple more that are finishing up clinical studies. So really a nice opportunity for us to extend really how we treat FemPop disease with a really unique platform.
When you approach these lesions, is there any role of imaging for these lesions as well?
Yeah, so it's always an easy question for me because the answer is always yes. I think intravascular imaging is in particular important for calcific disease and for any type of disease where it's failed prior intervention like in-stent restenosis. So really understanding the mechanism of failure, the type of morphology of the disease that you're treating, and trying to pair your device with what you think is best for that lesion. So for instance, if it's deeper calcium, we know intravascular lithotripsy is much more effective to that than a rotational atherectomy device,
right,
which is more luminal. So these are really important questions that can be answered on intravascular imaging.
Quick update, or at least answer for DCB versus stenting.
Yeah, so I have a session debating this later today about the role for DES versus DCB in particular. You know, I think these are complementary devices. I think a lot of us have always felt that less metal and less scaffolding is better for patients long term, and so that's why we really approach this with a DCB first strategy. But I'll be talking a little bit during this meeting about how in particular for long lesions, or lesion like at CTOs that were crossed subintimally, you typically need some sort of scaffolding to keep that vessel open, and then I think that's a great area where DES is going to shine.
And then in terms of length, is that length associated with more ISR down the...
Yeah, absolutely. I mean, especially when you get over 200 millimeters or longer, 20 centimeters of stenting, you know that your ISR rates continue to increase, and so even with DCB. And so we know with DCBs that you still fail with long lesions, and this is where potentially stents are helpful. We also don't want to stent head to toe, as you know, so I think it's a balance of how do we use both of these to get good patency, maybe some shorter term stenting, short segment stenting, complemented by DCB angioplasty.
Last comment on the medical therapy after you do intervention. What is your kind of combo of medication you give the patient?
Yeah, it's a great comment. We've always been drawn to aspirin Plavix, as you know. I think we've learned that at least in the peri-procedural time point, it makes sense to use aspirin and Plavix, but long term, that's probably not benefiting the patient much more outside of the acute intervention. So we do a lot of, if people are already on low-dose Xarelto, we'll keep them on it with aspirin. If they're not on it, we typically will do 1 to 3 months of aspirin Plavix and then switch them to low-dose Xarelto at the 1 or 3 month mark.
And
so trying to tailor.
Giving away what?
Giving away the Plavix usually,
Plavix,
yeah.
Awesome. Well, thank you again, Eric, for a very insightful, quick update on calcified lesion and FemPop disease. Thanks for watching us. This is Chadi Alraies coming to you from NYEVS in Manhattan.
Thank you very much. Thanks, my friend.